Hello, everyone. Welcome, and thank you for making the time to attend today's session, which Santech is proud to host. It's on a topic that's getting a great deal of attention in the payer industry, and that topic is the challenges that payer organizations are now facing around improving the quality of provider directories. My name is Bert Fajardo. I'm the VP of Strategy for Santech Solution, and I'll be serving as moderator for today's session. Leading today's discussion, I'm pleased to have with us David Gutwald. David is an accomplished healthcare executive with over 25 years of experience driving and implementing change in managed care organizations and payer organizations. Also on hand for later in today's session will be Andres Buitrago, Santech's Director of Product Development, whose 15 plus years of experience working with payer organizations has been spent focusing on how best to improve the quality of provider data, which today is ubiquitous in many organizations as well as in the industry. So let's get going by quickly running through the list of topics that David will be covering today. And these are to shed light on guidelines that CMS and state regulators are now imposing on payers, to highlight several challenges that payers are facing that's making it difficult to comply with guidelines and may result in fines, heavy may I add. David will then cover approaches and solutions that can be considered in addressing these challenges. And then Andres is going to jump in to provide a few highlights on how iNetwork from Santech can be leveraged by organizations to solve many of the problems and challenges that David will be speaking to today. And then we'll spend some time answering questions that you may have. And so we'll open it up for discussion. So without further ado, I'll now turn the session over to David.
So in our first bullets, we're going to be talking about some of the efforts that the plans are going into with regards to Medicare jumping in both on the on and off the exchange components, as well as under Medicare Advantage, CMS's guidance with regards to providers' directory information, which is creating efforts within our organization to complete additional outreach. We've all been doing it at some level with regards to outreach to maintain provider information and giving the providers access into our world of providing us with updates. But I think the key is, it's going to get into, as we'll talk later, it's on the payer's responsibility in a lot of respects to the regulations to make sure that whatever we're publishing on behalf of that provider as it relates to our payer and our contracts, that we are actually representing the provider effectively. So that ties into their addresses, their specialties, any services that they provide. It gets into how much level of information based on a payer mix that we're responsible or accountable for. It can even tie into languages and a variety of other types of demographics and pieces of information. I think the reality of it is, particularly in the Medicare world, those of us that have gone through, years of the process of developing plans and doing doing HSD submissions with regards to Medicare, we submit and we don't have to submit on a routine basis. They're starting to audit that activity. We are submitting, obviously, our directories on an annual basis at a minimum. So some of the 2017, this is an area where it's very much like anything else in our industry. We don't know until after the fact sometimes what the final regulations are going to be, but the reality is we have to start working towards any and all of it. Maintaining electronic format is not foreign to most plans that are out there today with regards to having directory information on our website. They'll want to standardize that. Looking at the actual data that's going to be available to the individuals that are either evaluating us from a marketing standpoint as well as existing members, making sure that the information is available and accurate to the to those folks. It gets into, overall maintaining all of our provider data, because we all know that even from the demographics and the directory side of it, that there are pieces of all of that that tie into other components of our business, whether it's claims processing, whether it's medical management and authorization, referrals, whatever the type of plan mix is out there. We've always been somewhat, particularly in the HMO industry, responsible for notifying members that are assigned to a provider when a PCP leaves the network. The plan, some of the talk is even when we've had to look at, you losing any type of provider in your organization, who is recently utilizing it and notifying those members that that provider is no longer with the organization. Some of us that work in a more of a PPO environment, the insurance company environment, that in and out of network has an impact on the members' cost share. At the same point, providers, when not contracted with an organization, do not have to accept the payment terms of the organization. So it tends to add more to it. Obviously, when we get into, there are 50 states. So on top of it all, we've got a possibility in some cases, if you're a national organization, dealing in, variations within the different states. This is a graphic that is just kind of highlighting the fact that the states are picking up on it. Some of the states that are out there, some of the states I've operated in, have always been very aggressive in terms of oversight of their provider information. You're going to see, particularly, between New York and New Jersey and even the state of Maryland, it's been key to some of those within those states. Some of that drives out of the Medicaid, some of it drives out of commercial, some of it drives out of some of the problems that the states have had with HMOs and insurance and plans, where they've not been able to maintain viability in those states. So this is just, again, more of a graphic of the different areas. I think as time goes on, we'll see more of those white states actually change color. Again, another graphic, as you can see, the various different frequencies. You've probably seen this if you've done research in terms of looking for your state or even other states. This graphic is not new in terms of those organizations and some of the research papers that we pulled that identify the different types of plans in the states and some of the activities that they're doing actually with regards to the frequency of how often they're going to review us. This will always tie back to their expectations of how often and how frequent we're monitoring and managing the accuracy of our provider data. So with this quote, we like this quote because one of the things that this helps to emphasize is the fact that there are states that are really encouraging, again, I'm going to go back to even the consumer, your members, for maintaining a vigilance on identifying inaccuracies with the provider data that's being published. So think about, in a Medicare environment, you have beneficiaries who think they're going to see a particular provider. They go out and they find out your directory says they're in their network. They go and call the provider to validate that information, and there's a good chance that if that provider contradicts you, that we're going to end up with a complaint. Whether the complaint comes to the plan, whether the complaint goes to Medicare, that can vary what the next set of actions could be. That same type of activity, as we've expanded coverage with ACA to the point of all of those additional beneficiaries that are now covered that used to be uninsured now have an avenue to, in essence, file a complaint if they see an inconsistency. They signed up with an insurer who said that their providers were covered, and then they go to those providers and they're not. So the challenge is out there for all of us, regardless of type, to really stay vigilant to our provider information on a regular basis. When we look at one of the key things, we've always, the question is always going to struggle with, is it really the payer's responsibility, or really is there ownership on the provider? The reality is the regulations, the contracts that we hold with our state licensures, with the federal government, if we're Medicare or on the federal marketplace, we hold a responsibility as payers because of that contractual relationship, and that trickles down to any of the providers that we represent. So, but the reality is the information comes from a whole slew of sources. You know, when we look at, you know, whether we're validating it, whether we're collecting it, we have opportunities to collect it from various different areas, but ultimately it's our responsibility with the provider. So that ties into our overall adequacy. So if we represent a network to Medicare or to a state that these providers are in network, that determines our adequacy in order to serve that population. So as we validate these providers and their service locations, because we all know it does tie down to, I can have one provider with 10 service locations. You know, it does get down to, we have to represent all 10. So if he closes 3 of them, 3 of those service locations technically have to come off our directory, have to come off our submissions. And they drive our overall adequacy with regards to providers and specialties. Think about it even to the point of the types of providers that are offered in each of those locations. We have to maintain the coverage. And again, particularly with regards to a lot of the state and then the Medicaid environment, you have to, you know, your access and availability is becoming more and more scrutinized. Panel capacity in the HMO environment. If PCPs are at capacity and they're no longer accepting from your payer mix, that we have to identify them, because if a member signs up and then tries to see that individual provider and the provider says, no, I'm no longer accepting patients into my panel, we have a situation. And then again, it will always tie back to, as we have more and more focus in the developmentally disabled and, you know, some of the long-term care, the community-based care, accessibility is becoming more and more critical for all of our payer mixes. Here's a primary graphic that, again, as you've looked at the various different components of the regulations as they come out, we all are at some level of risk now in making sure that the accuracy is there and what the compliance cost could be. We've broken this down into fines and, you know, fines, sanctions associated in terms of direct and indirect costs, as well as member satisfaction, because all have an impact on a payer's ability to sustain. So obviously the easy ones are in the, you know, I joke about the colors, the red and the orange, because these are things where you're accountable back to CMS, to the federal government. You can be fined in terms of, you know, your lack of attention to accuracy and credibility with your information. The last two are, you know, more attributable to our ability to retain. So when it comes down to it, if we have, you know, poor provider information, obviously we've got call volume issues, which will be member and provider satisfaction issues. So providers may opt to leave the organization, members may leave to leave the organization. But at the same point, if any of us that have been in the claims processing world, inaccurate provider information drives up adjustments, drives up inappropriate payments, checks going to the wrong addresses. You have a whole slew of activities, and that, again, it's a cyclic environment with regards to our call volume. And then again, back to the member satisfaction, you know, we're only successful if we can retain our members on a longer term basis. If we have a lot of, you know, and I'll use that word, I hate this word, churn, you know, we're not getting a continuity of that member across the spectrum of, you know, his or her a period of time, whether it's the entire lifespan, whether or not it's, you know, in a Medicare the last, you know, 10 years of their life. So as we've talked so far, we have to look at the fact that, you know, to the point of this slide, directory issues, you know, they're not new. we've been struggling with, and I've talked to friends and colleagues over the past 20 years, where provider data has always been somewhat of a bane of our existence when it comes to the accuracy of the information and maintaining it. Whether we're maintaining it from just purely the directory print process and the online directory component of it, or tying it, all the way through credentialing into the claims payment module. Provider information is a moving target. So obviously you can identify with areas where inaccurate listings on the directory. We've heard stories of providers that have deceased and are still showing up on a payer's directory file. You have obviously some examples here where some of the in the first one, 50% of the psychiatrists in the state of Maryland in a particular mix couldn't even be identified, couldn't be contacted. We obviously have to get to the point of more accurate information. Wrong provider types, driving individuals. We know that we struggle with the idea of their specialties, what their if we're publishing board certification statuses. This all ties back to the various different types of providers, representing them in the section of the directory that we want to represent them in. We'll always struggle with, the common mistakes between what I'll say is a provider that operates as both a primary care physician as well as a specialist, representing them adequately in our directories and in our data systems. Contact information is what's going to drive it. Again, that always ties back to the contact information that we're publishing not only in our directory, but even in our internal systems so that we have the ability to outreach those providers. Again, that ties to everything from a payer perspective. It's not just their service locations that you're publishing in the directory, but also any administrative locations, their billing locations, making sure that we know where we're sending the 1099s to on an annual basis. So some of the, this area we're going to talk about some of the challenges with regards to, the data challenges themselves. And Bert's going to drive it and make me sick with clicking. Overall, we're looking at, we've talked a lot about the provider directory challenges. Again, this ties into the payer's responsibility, but at the same point, keeping the provider in multiple places. We've got situations, we've got components where we've got demographic information, credentialing information, contract data, participating status. Think about this in the sense of, some of our own systems and some of the operations that I've, encountered where a lot of this information is kept in multiple locations. It's linked, we can associate it to one another by using things like tax IDs and NPIs, but it's actually not brought together and well integrated and to support all of the operations. We have the situation where we have various different owners. For those of you that are in, even small, even to large networks, you've delegated the efforts of maintaining the provider information. So you're just being fed information, whether or not you're leasing the networks. I've worked with organizations where I've rented the network, they've rented the network to me in terms of access. It gets into how that information, but ultimately I will be held accountable, particularly if I represent that as a service that my payer is offering as part of my representing my directory. Thank you. So in the next area, this is a very standard representation in terms of the fact that, to the last slide when we talked about having our data in somewhat disparate files in some cases, and many of us don't. A lot of us have tried to move towards more of a relational data set. But CMS is pushing us all to provide more of a relational data structure where we're tying together all of these components. And that gets into some of the things that have always been more of a data information pace. Is, like hospital affiliations. We don't always think of it in a commercial or even a care environment, the relationship of the various providers to that hospital and representing that, whether it's in our provider data, on our online directories. It's definitely not in our printed directories outside of, again, another piece of demographical information. But you can't go into a paper directory and say, I want to see all of the providers that have an affiliation or services at this hospital. So by creating that relational database and you create that online presence, I can now go in and say I need an orthopod at hospital X, and it will show me who, if I select this provider, would most likely select this hospital to provide the services at, particularly if I think I need rotator cuff surgery or whatever the case might be. So we've got to, obviously keep moving towards, our overall responsibilities from the payer perspective, but even to the point of, and I'm always going to go back down to the provider has to start to own some of their responsibilities to this. No different than members having a responsibility. For those of you on the call that deal in the member world, you recognize the fact that members have to own their own benefit plan. They have to understand, what their responsibilities are, whether we're sending them an STD, whether we're sending them a member handbook, whether we're sending them an EOC. It's a matter of understanding their own contracts. But ultimately, at this point, we have to understand the provider's challenges. They don't always have the same avenue. Think about, particularly in the smaller providers. Now, the arguments out there are going to be that a lot of the smaller providers no longer exist. They've been bought up. They're part of larger groups and affiliations. They should have their more of a bandwidth to provide those services. But experience shows us that that's not always the case. They haven't invested their time and energy into maintaining, an accurate provider data with all of the various payers. A lot of them are out there, just trying to survive. So when we look at maintaining the provider-payer relationship, it may be as simple as I know who I can bill because I built up those insurance codes in my practice management system. Tracking changes as physicians move in and out of a practice, and the network changes, who I'm affiliated with. It's not been, on the provider side of it, it's not always been as much of a drive. Their focus is going to be their patient mix, their EHRs, and their practice management systems, maintaining what we would say is, our information as payers on their system so that they know they can submit claims for payment. And then they spend, obviously, a great deal of time making sure that they are getting payment for the resources. Some of the larger systems that are out there that I've encompassed, particularly in the Mid-Atlantic region, have much more stringent opportunities where they actually can price the claims out based on a payer mix. And those are, again, not so much at the physician or the provider basis, but some of those are at the health system level. Now we're going to spend a little bit of time just talking about some of the approaches. Some of these things you guys have probably already encountered. You've either lived through some of these opportunities, are thinking about doing some of these things, are doing them right now. And there's a breakdown. I mean, you can always outsource it. You can give somebody your data and have them do the outreach and update that information. But that's a one-off. I mean, that will provide a solution just for the provider directory and the service location. You can use an aggregator. We've all, and a lot of us use CAQH. We also know that, with regards to CAQH information, it's not always as accurate as the current information that's out there. So you've got some, some opportunities there with regards to, reaching out to other organizations that have already been in the sphere of collecting the information, but it's really on the outreach to the provider that's still somewhat lacking. We're expecting the provider to come in and not really giving the provider tools to even get in and keep it and maintain it. Or you can go down the road looking at, more of an integrated approach. This can be something you build yourself. This is something that you might find other products in the industry. Obviously, this is one area where, I've watched, some of the development and the efforts with the iNetwork solution, where we have a structured approach to maintaining and bringing in the information, maintaining everything through the credentialing component, generating records with regards to outreach, who hasn't been updated on a regular basis, what was the last piece of information, mimicking that against some of your own utilization information with regards to claims that you've paid, particularly on an outer network basis that somebody's coming in network. We want to make sure that we've got consistent information, pulling the information from even some of those aggregators that are out there in terms of our own, ability to bring the information in on a startup basis. And I think one of the key things, and this is where we're going to bring in, I'm going to bring in some of the folks from iNetworks to talk about in terms of the solution, is really giving tools to the providers. Not something that, in my past we've built into our process, but giving tools to the providers. The one thing we want to identify, and I want to just highlight, the overall accountability of the first two is really going to be stuck on the payer. You're really not engaging the provider. It's all on the payer to really do the outreach, or to pay somebody to do outreach, to update the information. Here we're going to go into a directory solution.
Yes, now I'm going to introduce to you Andres Buitrago. He is the Director of Product Development for Santech, and he's just going to touch lightly on some of the capabilities of first iEnroll and then iNetwork. And for those of you that don't know, iEnroll is the solution that is being used by providers and large provider organizations to better manage their information, which in turn makes it easier to help payers comply with their challenges that they're facing with regards to compliance with directives. So I'll turn this over to Andres.
Thank you, Bert. Good morning, everybody. So iEnroll is one of our two core platforms here at Santech. It's used primarily by the physician practices, ranging from solo practitioners to the larger practices. They use our solution to collect and maintain all of their provider roster information. In addition, they are able to upload and attach all supporting documents that are required by their payer affiliations. Now, traditionally, they've been maintaining the data in either an Excel spreadsheet or an Access database, and the documents sit either on our desktop or somewhere in the filing cabinet. In any case, this has contributed to the information being outdated and inaccurate. Now they are able to utilize our solution as a single source of truth. From the point of entry, we put all of our data through various validation checks. We check for address validation, NPI, duplicate records, and aliases. Those are some of the validation checks that we do in efforts to reduce the data contamination. Once the provider record has been established, they have also a notification system that alerts them of upcoming expirables. This mechanism assists the providers tremendously to proactively communicate to the payers of outdated information. This is big now, especially with the scrutiny that CMS has put on directory information. Practices find it far much easier now to respond to the payer requests, having one single source of truth, one place to make all changes to their profiles and communicate it to all payer affiliations.
Yes, any comment on that from if they're involved from the provider side? Diane, I think you're out there, right?
Yes, I'm here. This is Diane Plott, and I am the Manager of Credentialing at Lexington Medical Center in West Columbia, South Carolina. We have about 300 mid-levels, and we have about 300 to almost 350 now of MDs and DOs, and we are a customer of Santech, and I enroll, and I've been reviewing everything that has been presented today, and I would just like to interject and share with y'all that one of the best things that we found with this whole system is that data management, being able to catch things, accessibility. It's a good marriage put together because we're able to extract information, but we're also able to put information in. And our biggest thing right now is the possible risk of missing something as far as DEA renewals, and especially things that we need to manually usually do that we now can do electronically. Because manual was our big thing. We had a spreadsheet for absolutely everything you could think of, and for us, this was one solution that would help us.
Now, if any of the provider directory requests are received by practices, it'll be much easier to process them and submit them to the respective payers?
Yes, that's correct. If we're requested of that, that makes a difference. We are currently, LMC is going through a huge renovation and expansion, and we are constantly having address changes. Practices are moving due to construction. Practices are moving throughout Lexington County, Richland County, and moving into other ones. And it is our responsibility to make sure, because as you said, things are no longer necessarily printed in a book, and if a patient wants to go see somebody near their home, which a lot of people do, you want to be sure that that office is there, so when they call, they're going to be able to get an appointment with that physician in that area. So for us, not only just the group information, but making sure that all those providers, everything is lined up correctly with the payers in regards to those directories, because that is the one source they're going to go to, and of course, especially if they're trying to find a provider near them, and of course, we want them to come to one of our providers. You have to keep up with that.
Thank you, Diana. We really appreciate that interjection. And I think just to add to that, or elaborate on it, it's more that, to David's point earlier, the payer organizations are still accountable, but unless there's a means and ways to make it easier for the providers to submit this information, it really is going to continue to be an uphill challenge.
Correct.
So, thank you, Diane.
You're welcome.
And then on the payer side, Andres is going to touch a bit on the capabilities of iNetwork and how it can help payers with more easily addressing these challenges that are being posed by the states and CMS.
iNetworks is our enterprise caliber solution that is used primarily by the payer organizations. They use our solution to manage all of their provider networks, whether it be proprietary, delegated, or leased. iNetworks becomes the primary source of truth, not only for provider data, but also for all of the supporting documents. Now, at every point of entry, whether it be data entered or through an upload, all data is put through rigorous validation checks in efforts to minimize data contamination. Also, throughout the provider lifecycle, we run a log of all transactions on a provider. This can be leveraged with our notification feature to alert the payer of all outdated provider information, as well as any credentials that are set to expire. This notification can also trigger outreach campaigns, which can consist of blast emails, blast e-faxes, generate call lists, and generate letters. All of these outreach efforts are logged as well for compliance purposes. Now, if the provider is an existing iEnroll account holder, or if the provider is to respond through the temporary iEnroll account, the payer will receive all changes in iNetwork identified as to what was there before and what is the change they're proposing, and then the payer will also have the ability to deny or accept the change. All of this is logged in the historical transaction log of the provider, which then later can be extracted for compliance purposes. All these functionalities become very important now with the scrutiny that the directory and provider data has received.
Thank you, Andres. And I think the message here is more that, so we have a solution on the provider side, and then we have a solution on the payer side. And the real magic comes into play when we have customers where you have a payer in iNetwork that can engage with providers who are on iEnroll. And there, iNet Exchange allows for that all to be done, in digital fashion instead of transmissions from one to the other with different formats. Take it a step further, and the more payers that we have on iNetwork, okay, and the more that the information coming in from providers, that can be actually compared and validated against the different instances of their information with different instances of iNetwork. So it really provides the payers with the ability to see the information that's coming in. Is it really the most up-to-date? And it's their call to decide whether to use it or not.
So our iNetwork's provider directory solution is compiled into 6 steps. So once the provider files are ingested and data cleansed, where we are able to pinpoint any duplicate files, formatting issues, and invalid data, the request will then, once the time frame is up for validation, it will generate a notification that will be transmitted over to the provider practice so that they can engage and log in and validate the information. Once the information is validated, the provider will log on to iEnroll, make necessary changes. It'll be communicated over to iNetworks. And then the request will be received, processed, date stamped for compliance purposes, and it will be made available to be published in the directory.
Now, just to add to that, the interesting point here is that if a provider is not on iEnroll, our solution accounts for that by actually creating a temporary license that your payer organization can allow them to use so that they can basically use iEnroll to submit their direct dates to you. And if they so choose, they can become a customer of iEnroll to use that same solution for all the payers that they get requests from using iNetwork. So at this point, what we'd like to do is just field any questions that the attendees may have out there. There is one question out there as to whether this will be available, the slides from this, and the answer is yes, it's actually being recorded, and we'll make that recording available to those that request it. Just send a request to me. You receive the email from me, and I'll reach out to you as well and see if you'd like a copy. At this point, are there any questions out there? Sure, David, maybe you have one.
I'm going to throw a question out to you guys in terms of the overall solution. I mean, ultimately, it would be good for the exchange, between iNetworks and iEnroll, but ultimately, it's not a requirement on the payer or the provider. The providers can sign up through iEnroll and support pushing information to the various different payers, and the same thing from the payer perspective in building that out. But I think what I'm trying to figure out is really understanding that interaction when you talk, one of the leading issues with solutions that are out there is creating more work for the provider. So by sending that notice to the provider, are we creating a level of effort, or is it a simple validation of a click on an email that says, yes, that's still my accurate information, click, I'm good? I want to make sure that, we're addressing and you're addressing the provider's burden of some of this stuff. So if we're providing them the information and if they don't have to update anything, it's relatively seamless, right?
That's absolutely right, David. So if everything's intact, it's just a matter of a click acknowledging to the payer organization that their information is up to date. If there is an update that's required, it's a matter of just updating information, okay? Because actually the payer may have information that's out of date and the provider may be more current, okay?
Yeah, no, I completely agree with that, your approach. I just, again, trying to think of it from the provider side of it, some of the complaints as payers that we get by sending them mailings that say, is it still accurate, and they're supposed to fill out a separate sheet of paper and mail it back in, and I deal with every type of format in that situation.
Exactly. Any other questions out in the field there? You could be vocal too if you like. You don't have to text your question.
Bert, this is Diane.
Okay.
If you would, I would just like to say how y'all have your, the one reason why we chose to go with y'all for the people that are out there listening. I think it's really important that they understand that I can tell you from personal experience that I did a lot of research on different companies to go to and that could provide us, and a lot of companies can provide you with this information and with the software, but it was the level of customer service that we received and we still receive. I think a lot of software companies out there are there to sell the software and that's it, and then you're basically left. Or there's other things that are associated with it, and that is the one thing that it was an extremely high level of customer service and things like that that we felt was the most important to us, and we still receive. So I just wanted to interject that.
I appreciate that, Diane. We all do here. Thank you so much. And I think, that what you just described there is the approach that we took in developing a solution that our customers could use to deliver better customer service to to their stakeholders. So I guess that's part of the DNA of our company and our product. But thank you, Diane. I appreciate it.
You're welcome.
Okay, and just check and see. Okay, then on that note, I think I'd like to thank everyone for taking the time and to join today's session. And what I'd like to do is I will be following up with those of you who signed up and attended today.
Could you also be at
I'm sorry?
You'll be at AHIP.
Yes,
Thank you.
And I think some of you on this call will be at the AHIP event next week. So I encourage you to stop by our booth, and I will be there along with Andres, and Neera Sharma, our COO, will also be in attendance. And with that, again, thank you, everyone. And I'll also be following up to get any feedback that you could provide regarding today's webinar. And if there's anything we could have done better on this end, we do plan on having some more of these on not only this topic, but others that are of importance to the industry. So thank you, everyone, and have a great day. Take care.